Hello and a warm welcome, everyone. My name is Anna Karthaus. I'm a medical doctor and science journalist, and I have the great pleasure of moderating today's panel discussion on endometriosis, put together by the German National Academy of Sciences, Leopoldina. As we have only 1 hour to cover a huge topic and to give the women that we're talking about a voice, I would like to jump directly into the matter by starting off with a couple of quotes from women suffering from endometriosis. The pain is like barbed wire wrapped around your insides and someone's pulling it. I wasn't able to be intimate with my partner very often unless I was dosed up on medication. Over 11 years, I've been hospitalized maybe around 50 times. The years of not being treated mean I have had to drop out of my dream career. I texted my boyfriend and said goodbye. I was ready to end my life then and there because of the pain. I'm sorry to draw such a grim picture of a disease that presents itself in so many different shapes and forms, most prominently, though, through severe pain or infertility. And I'm sure our outstanding panel guests today can add many more examples from their personal and professional experience. Endometriosis affects roughly 1 in 10 women of reproductive age, which makes it as common as diabetes. But because of its, so to speak, chameleon-like appearance, many women, it often takes many years, sometimes more than 10 years, for an affected woman to be correctly diagnosed with endometriosis. And even then, the journey is often not over, as there's still no cure for endometriosis available today. When talking about endometriosis, there are many unknowns. We still don't fully understand what exactly causes the condition, how and why it develops, and most importantly, how it can be cured. As we have only an hour to cover these questions today, we will probably not be able to solve the problem of endometriosis today. That's partly because we just don't have a lot of the answers. And one part of today's discussion will also be why that is the case. On the positive side, though, what I can promise you is by bringing together leading international experts to discuss the latest findings and advances in the realm of endometriosis, today's conversation will at least contribute in changing the narrative in the future. And I would like to welcome our distinguished panel guests to today's conversation. Hello, everyone. And I would also like to welcome you, dear audience. It's great to have you with us on board. And I invite you to actively engage in the conversation by asking your questions. You can do that by directing them, sending them via the Q&A function or F und A function if you have the German Zoom installed. If you wish to assign your question to a specific panelist, please indicate that in the question. We will collect your questions and address them in the second part of the Q&A. But before we dive into the discussion, I'd like to first introduce each one of our experts one by one and give them the chance to talk about their particular field of expertise in a short input statement. And I would like to start with Stacey Missmer. Stacey, great to have you here on board with us. You are a professor of obstetrics, gynecology, and reproductive biology at Michigan State University, an adjunct professor of epidemiology at Harvard School of Public Health, and current president of the World Endometriosis Research Foundation. Besides, you are an endometriosis patient yourself, which, as you told me in our preliminary talk, has had a huge impact on your professional career choice. Stacey, as a biologist, and to get us started off, could you talk a little bit and give us an overview of what we know about the biological foundations of endometriosis, how the disease presents itself, as well as other health conditions that it coexists with or that it can lead to?
Good morning. It's a pleasure to be here. Yes, as you just described, I was a teen who, with my first menstrual period, had life-impacting pelvic pain and was told frequently that it was normal, was told that really if I was just taking paracetamol and being less stressed about it, that everything would be fine. And my symptoms continued to worsen well into my 20s and really did alter life trajectories, which started me on the path of, as a scientist, trying to better understand endometriosis. And what we know now is endometriosis is defined as the growth of tissue that functions like that within the endometrium, but it's growing now outside of the uterus. And so this tissue in plants thrives. It is innervated, it is vascularized. It can be cystic on the ovary, for example. It primarily appears within the pelvic and peritoneal cavity. However, it can be found in multiple locations across the body. There's thoracic endometriosis. There are patients who, for example, have cyclic nosebleeds with their menstrual cycle. And this tissue responds and behaves like the tissue within the endometrium throughout the menstrual cycle. And so it builds up and sloughs off, resulting in scarring and adhesions. There is localized, but also systemic chronic inflammation in patients with endometriosis. And the symptoms that we understand now are primarily, again, life-impacting pelvic pain. It can be specifically with menstruation, dysmenorrhea. It can also be acyclic. It can include bladder and bowel pain, GI symptoms of nausea, vomiting, abdominal cramping, and also infertility. In addition, actually the most prevalently reported symptom is fatigue, that there are, again, multisystemic life impacts. These also result in women with endometriosis have a higher risk of multifocal or widespread pain. There's often co-occurrence with migraines, backache, joint pain. And also women can have a higher risk of, in the future, developing autoimmune conditions such as rheumatoid arthritis, lupus. There's also an increased risk of cardiovascular and cerebrovascular disease, higher risk of hypertension, hypercholesterolemia, a higher risk of stroke, earlier onset heart disease. And then we know that the most prevalent higher risk is of ovarian cancer. It is still a low risk overall, even in those with endometriosis, 2% across the life course. However, we don't know yet, although we suspect that this is related more to those with endometriomas. This is an area where we know that endometriosis presents primarily as superficial lesions, as endometriomas, which are those cystic lesions on the uterus, or I'm sorry, on the ovaries, and then also deep endometriosis. But we know that those presentations don't correlate well with symptoms. They don't correlate well with treatment response. And this is an area where science is really moving forward. We know that those with a higher volume of retrograde menstruation, so when menstrual effluent moves up through the fallopian tube into the peritoneal cavity, has a higher risk of endometriosis, but most women experience some level of retrograde menstruation. And so there's heightened etiologic pathways through immune dysregulation, hypoestrogenic milieu. We know that there's stem cell involvement, there's coelomic metaplasia. And so it's a complex disease with definitely not a single pathway, but with multiple pathways to producing the disease, and therefore multiple pathways for potential novel treatments and therapeutics. It is one area of excitement of trying to better define what those classifications of endometriosis are, classifications that correlate well with symptoms, that can be more predictive of prognosis and can aid physicians in selecting a likely beneficial treatment course. We're now seeing with genetic discovery, we have 42 loci identified for endometriosis, and that reveal, again, inflammatory, angiogenic, multiple pathways. But also, those genes so far are primarily associated with endometrioma presence. And so we have quite a bit of work left to do in terms of subphenotyping. We have emerging data that the proteome, the proteins associated with endometriosis vary by symptom presentation, also may vary by response to treatments. And so there's really great efforts that have increased recently in terms of exploring this very complexity, and as this panel is defined, the chameleon-like nature of endometriosis.
Great, thank you very much, Stacey. I think it's so impressive to hear also from you how many faces this disease can have and in how many-fold ways it can present itself. So I think that sets us up very well for the debate later. Thank you very much. I want to bring in our second panelist, Bettina Toth. You are the director of the Department of Gynaecological Endocrinology and Reproductive Medicine at the Medical University of Innsbruck and president of the Austrian Society for Gynaecology and Obstetrics. Besides, you've been working for more than 15 years on setting up guidelines for the diagnosis and treatment of endometriosis in the German-speaking region. So, as a clinician and with a very hands-on experience, I'd like to ask you to tell us a bit more about how women present themselves in your clinic, how you proceed in diagnosing the disease, and as this is a major part of the disease and your research focus, what we know about the link between endometriosis and infertility. Over to you.
Thank you so much for the invitation. It's not that easy to answer the question, how is endometriosis diagnosed? Because generally speaking, it's definitely diagnosed by laparoscopy and tissue biopsy and a thorough examination by a pathologist, because only then you can really prove that the tissue you are looking at is endometriosis. So endometrium tissue outside the uterus. But of course, not every patient needs a laparoscopy. So within our university clinic, we see young girls with heavy menstrual pain, even at the onset of uterine bleedings. And in that case, we make sure to exclude other risk factors for menstrual pain, for example, uterine or anatomical malformations. And our examinations with young girls primarily focus on transabdominal ultrasound, and in some cases, even an MRI is needed. But of course, most of our patients are above 20 years of age, and some not only report heavy menstrual pain, but also pain during sexual intercourse. And in that cases, you might find changes in the texture of the uterus during gynecological examination, or you even might examine enlarged ovaries, like mentioned before by Professor Missmer. And with regard to gynecological ultrasound, there are many signs you might find in patients with endometriosis, like changes in the different layers of the uterus, endometriotic lesions in the ovary or in nearby organs. And so this might be a way to diagnose endometriosis. And the other very, very important aspect we are dealing with our endometriosis patients is there a link between infertility and endometriosis and vice versa? And that's also no easy question, and it's not easy to answer. But to my opinion, the link between endometriosis and infertility is due to the fact that in women with childlessness, we often find endometriosis. But this does not mean that every patient with endometriosis suffers from infertility. I think this is very, very important to mention, because patients with endometriosis are very afraid whether or not they can have a child. And so it's very important to state that not every patient with endometriosis is having a hard time when she has childwish. And the reason why patients with endometriosis might suffer from infertility are various, like mentioned before by Professor Missmer, because endometriotic lesions undergo a normal menstrual cycle. So when we do laparoscopy, we really find dark red spots. And we know that these lesions interact with the immune environment. So that's one pathomechanism. And the other aspect is that endometriotic lesions might be inside the ovary, so might affect the quality of the oocytes. And of course, you also can find endometriotic lesions in the tubes, so in the fallopian tubes, and or outside around the fallopian tubes. And these lesions might disturb the interaction between the sperm and the oocyte.
Great, thank you very much. I think what's also super interesting, what you told me in our preliminary chat, is that the symptoms that a woman has don't necessarily need to match with the extent of the disease. And that can also make it so difficult to diagnose the disease when you have a woman presenting herself with like severe pain, but you don't see anything, which is the perfect bridge also to our next panelist. I'm very happy, he unmuted himself already, that we're joined by Matthias Beckmann today. You are a professor of Obstetrics and Gynaecology at Friedrich-Alexander-University Erlangen and director of the Endometriosis Center at the University Hospital Erlangen. Besides, you've been heading the Guideline Commission of the German Society of Gynaecology and Obstetrics for more than 10 years now. Matthias Beckmann, there is currently no known cure for endometriosis, and treatment is usually aimed at controlling symptoms. So can you set us up a little bit with which therapeutic options exist and what makes it so challenging, so particularly challenging to treat endometriosis patients, and what the role of surgery is or is not?
Anna, thank you very much. I would come back to your question, but I would put one question before that. Who is treated? I think that is the major question, not how do we treat, but who is treated? And the point is, as Bettina and as Stacey both mentioned, we have a broad spectrum of symptoms, and infertility is one broad symptom. As you mentioned, the pain is a second, and we have a group of endometriosis patients who do not have any complaints. So that is one thing I would state first, is a woman who has endometriosis accidentally diagnosed by another operation or by an ultrasound does not always need treatment. So I think we should exclude a group of asymptomatic, non-complaining women from the option of offering them treatment or forcing them to get surgery. What treatment option do we have? I would not go, as Bettina's already mentioned, in infertility. This is a special lecture. I would go for pain, which is a major complaint of more than 70% of the patients who have endometriosis. And there it is, we have three major options to use. The first option is hormonal treatment. So you can use either in, I don't know how it is in England and how it is in the US, what is allowed to give. We only have one drug, which is Gynaecology. That is the only reimbursed drug we have in Germany for the treatment of endometriosis. And now, since November last year, we also have Reproductive, both specific hormonal treatment for women with diagnosed endometriosis and complaints, in this case, pain. Then we have the analgetics, which everybody knows, like ibuprofen or paracetamol or other painkillers, which is also one option to treat, not to treat endometriosis, but to cope with the symptoms of endometriosis. And then we come to the last part, surgery. As I think Stacey mentioned, the gold, or no, Bettina, the gold standard for diagnosis is a laparoscopy. But at present, we in Germany, we decline from that statement and say we also, if we have an MRA or we have an ultrasound, we would treat the woman with a hormonal treatment, not necessarily offering them surgery. So surgery is, to my opinion, that what we can offer to a woman who has no options after using painkillers, after using hormonal treatment, and then still has the complaints, then surgery is an option. Whenever you can, try to do it by minimally invasive access. If it doesn't work, then you have to use an open access. And with organ destruction, endometriosis, there you have to offer them surgery, as involvement of the bladder, involvement of the intestine, or involvement of the urethra. If you don't want to lose a kidney, you don't want to have problems with the bowel movement, then there surgery has a place. But to have the chain, it's first who has complaints, what are the complaints, then the hormonal treatment, the energetic treatment, and then surgery is after the others do not work sufficiently for reducing the complaints.
Great, thank you very much. I'm sure we will get back to a couple of your points. One being, for example, women who wish to become pregnant, but at the same time, hormonal contraception is one of the prevalent therapeutic options. So how do you proceed with these women? But before that, and to zoom out a little bit, I want to bring in our fourth panelist, Nicky Hudson. Nicky, you are a professor of medical sociology, leading the Center for Reproduction Research at the Montfort University in Leicester. And I'm very happy that you're with us today to help us shed light on the socio-cultural dimension of endometriosis, an aspect that we didn't touch upon in the last input statements, and which is very, very important when talking endometriosis as a neglected disease. You will talk about that more. In our preliminary chat, Stacey Missmer said, and I think many women, including myself, can relate to that menstrual pain is the only pain we consider to be normal, which is crazy. And you wrote, Nicky, you wrote a paper on endometriosis as the missed disease and told me that it has been willfully ignored because menstruation is something that's just regarded as stigmatized, as shameful, something you should not talk about. So could you talk about a little bit what role the social and cultural aspects play in relation to endometriosis, why the disease has remained largely ignored in government policy and research funding, and possibly how this can be changed?
Thanks, Anna. Yes, I'm happy to contribute. So we've heard already how endometriosis is considered chameleon-like, and I think the other speakers have articulated that really clearly. But what I want to talk a little bit about is how not only is it chameleon-like, but that it's been missed. And one of the kind of defining features of endometriosis is its invisibility. If that's not too much of a contradiction in terms. So when we think about the kind of social and cultural aspects of a disease or a condition, we're thinking about the aspects of that condition that go beyond the individual. So how is it seen in culture? How is it represented on the media? How do workplaces organize themselves around a condition? How is it talked about in social context? Whether even people know what it is or not. So it might include historical, political, and economic aspects of the condition, for example. So one of the main factors, there's obviously a lot to talk about there, and one of the main factors is this sense of it being an invisible condition, and many people have talked about the condition being missed. So in the paper that I wrote recently, I talked about how endometriosis is an example of what we might consider to be undone science. And I think all of the speakers so far, and Stacey mentioned that there's work to be done in terms of thinking about endometriosis, what it is, how we treat it. And I think it's been missed in a number of ways, and we've already heard how there's no cure, that we haven't had any new treatment for several decades now. And I think one of the biggest ways in which endometriosis it regularly gets missed is the fact it still takes over 7 years to get diagnosed. And there are a couple of main things that I want to draw attention to in relationship to kind of social, historical, cultural factors. And one is its relationship with menstruation and menstrual health. And for a long time in many cultures, menstruation has been considered something to be shameful or dirty, to be hidden, not to be discussed in public. And so endometriosis has suffered from being linked to that historical discourse of needing to hide menstruation, that it shouldn't be something that we talk about in public. And so people have talked about this idea of menstrual etiquette. You know, we don't talk about periods in public. And so actually it's remained hidden partly because of that idea that anything related to periods and women's health in general should be hidden. And so that's not just a case for people experiencing symptoms, but we know from people living with the condition that they also experience this in in encounters with healthcare professionals as well. And Stacey talked about this experience of having your symptoms delegitimated in healthcare encounters, being told that painful periods are just part of being a woman, or you're one of the unlucky ones when it comes to painful periods, and pain is something really to be endured. And only really recently is that dialogue and that kind of representation, I think, started to shift, and people are starting to think about menstrual health as a kind of distinct area of concern, and there are many reasons for that, one of which is the historical context. And there's a much longer history here, and many historians and commentators have argued that there is a link between how we view gynecological health now and how it has been treated and viewed historically. And one of the classic examples that is often given is of the ancient Greeks and the idea of hysteria, and this idea of women's the uterus wandering around the body causing behavioral disturbances. And because of that historical context, a lot of research that could have been done about conditions that specifically affect women and others with female sex-linked biology is that they've gone under-acknowledged in medicine and science due to an assumption, a long-standing historical assumption, that women are by their nature sicker, weaker than men, and those conditions haven't been seen as legitimate illnesses worthy of scientific attention, but actually it's been seen as evidence of women's weaknesses. And so that's led many to hypothesize that many of the conditions that we see today, polycystic ovaries, for example, fibroids, menopause even, and endometriosis were attributed to this idea of the wandering womb and women as being kind of weaker beings. So the implications of that historical context are that we've had a problem with underfunding of conditions for a long time, of conditions that tend to predominantly impact women. So it includes endometriosis, but it also includes things like migraines, chronic fatigue syndrome. And there's been some interesting analysis recently of the amount of scientific funding that is awarded to conditions that traditionally impact women. And we find that compared to their burden, so they may have a huge burden for the individual and for the kind of economic burden, they attract a much lower level of research funding. So that's where this idea of undone science comes in. It's this idea that knowledge about something is partial or missing, and that persists despite the calls from the public or people living with a condition for that to change, that we've had this persistent and willful ignorance around certain conditions. And endometriosis is a classic example of that, where there has been campaigning, at least in the UK, from people living with the condition to bring about change for many years, but their voices have remained largely hidden until recently. And I think one of the ways in which we see that is, for example, we didn't have a clinical guideline for the treatment of endometriosis in the UK until 2017, which is quite remarkable. So we've had decades of ignorance around the condition, which means that there hasn't been funding for the science that, you know, our clinical and scientific colleagues need to be able to do. So what can we do about that? And is there any change on the horizon? And Anna asked me to speak about this particularly. And I think the fact that we're all here today is a really positive sign of change in this regard, that endometriosis is being talked about a lot more regularly, being debated, appearing in documentaries, in social media and so on. And I think in the UK, we've recently had the Women's Health Strategy, which has its problems, but nevertheless, partly one of the problems is talking about endometriosis as only impacting women. Of course, it impacts on trans and non-binary people as well. But that strategy, I think, has set endometriosis as one of its central themes. And I think that visibility that's been given to the condition through that kind of political shift is really important. We also have work going on in the UK in schools to educate young people about menstrual health more generally, including conditions like endometriosis, and a huge amount of public awareness. For example, employers are increasing to Endometriosis UK, the main charity in the UK, has an endometriosis friendly employer scheme, and more employers are signing up to that. So hopefully these shifts are signs that things are moving, and we will start to move into a space where we're seeing more funding. And I know that some European countries are now starting to develop funding strands and programs specifically targeted around women's health and endometriosis. Not yet in the UK, but hopefully that will happen soon. And of course, we've got a current trial around a new treatment for endometriosis, which I think is, again, our clinical colleagues can talk more about that, but is a really positive shift. So I think it's not all bad news.
Great, Nicky. Thank you very much. Thank you very much to all four of you for these very interesting insights and the different aspects that this disease has. Stacey, you spoke about that, but I think we should still dive a little bit more into what we know about the causes of endometriosis. And because there are several theories floating around, you spoke about some of them, but I want to incorporate also our first question from our audience. So could you talk a little bit more about the cause and risk factors? You've done work on that, about environmental and physical risk factors that are also at play when talking about endometriosis. And what do we know about the potential link to a specific bacterium called Fusobacterium, which has been a recent paper published by a Japanese research group?
Absolutely. I think the Fusobacterium is an example of some of the novel and exciting discoveries that are now happening in the endometriosis space. It is getting, as so well described by Nicky in particular, is that there has been a lack of attention. There's not adequate attention yet, but there has definitely been an increase in scientific and clinical focus and at the national and individual level of late. And for example, this type of study identifying a higher proportion of flora of this particular bacteria that was found to be more prevalent in patients with endometriosis. I think a key thing is that each of these novel studies happen in very small patient groups under very specific circumstances. We have to remember that endometriosis evolves in patients across their life course, expressing different symptom manifestations, different treatment responses. And so it makes sense that in different populations of patients at different times in the life course, we do see these different markers and potential etiologic factors. That doesn't mean that we're getting it wrong or that endometriosis is too confusing. And I like to use the example when I talk to lay populations of lung cancer that is more publicly known and readily accessible, that we know that cigarette smoking causes lung cancer, but also radon causes lung cancer, asbestos causes lung cancer, specific particulate matter and air pollution causes lung cancer. So that there are multiple potential etiologic pathways for endometriosis is actually just quite consistent with other complex diseases. Also, in the reverse, we know that there are exposures for endometriosis, such as we have evidence that a diet, for example, that is high in trans fats but low in monounsaturated fats, and such as omega-3 fatty acids and things that we know are quite broadly of health benefit, that trans fats are more prevalent in the diet of patients prior to endometriosis diagnosis, and also can be associated with symptom presentation. Diet higher in red meats, for example, potentially a more hyper-inflammatory diet can be related with endometriosis. We know that women with endometriosis on average are more lean than those without endometriosis. And so that is a pattern that's also seen, for example, in risk of premenopausal breast cancer. And so there are lots of these potential risk factor indications. We know that exposure to phytoestrogens and estrogenic toxins in the environment, such as dioxin, is also associated with increased risk of endometriosis. And so there's many pathways to explore, which is both exciting, but also can be overwhelming for determination of etiology. But it's not going to be just one answer. And that actually is a benefit and a strength to our discovery, not a detriment.
Yeah, very interesting, this aspect, benefit and strength of of the challenges. Great that you can also turn it in a positive way. Matthias Beckmann, maybe a question to you. Over the past years, the scientific community has seen and has gained an insight into certain hallmarks of endometriosis and that play a role in the genesis and in the progression of the disease. How does that pave new ways in diagnosing, talking about biomarkers here, and treating the disease, talking about drug targets? So what's in the pipeline at the moment? What promising therapeutic options are currently being researched in clinical and preclinical trials?
We wrote a review article about the various pathways, as Stacey mentioned, who are involved. However, up to date, the only medication which is used are hormonal treatments. So all the other things as we use, like inflammatory drugs, neoangiogenesis inhibitors, or other things, are not used in clinical use. There are studies which begin to be promoted. However, from my point of view, one of the major problems is endometriosis, the disease, severe enough to take, for example, biologicals, which have also a huge amount of side effects, as we know from other disease. So I think as we went over all the studies, that was one of my major thoughts is, do we really use those biologicals in endometriosis people, endometriosis women, and get them all with the side effects? We know it from rheumatic arthritis. You said migraine. We know that from other diseases. So that is, to my point of view, I think we could get progress because we have biologicals in other disease. But the question is, do we have the chance to transfer this for endometriosis? And then if we do that, we have to have a diagnosis, because that, for example, only do an ultrasound on MRA and getting it might be, and then using a biological with side effects. This is very strange.
Yeah, thank you very much. Talking about side effects here, not only biologicals would have huge side effects, but also the treatment and the therapeutic options that exist at the moment have side effects. Bettina, Toth, maybe that's a question for you. You see many women presenting themselves with the wish to become pregnant. At the same time, hormonal contraceptives is one major brickstone of therapy at the moment. So how do you proceed with these women that present themselves? And yeah, how do the therapeutic options look like for these women?
I think it's very important if we talk about child wish, it's not only about the women, but also about the male side. So we definitely have to check also the male part, the sperms and the general health condition. I think this is very important to mention. And then when after a thorough diagnostic check for both of them, and you might identify not only endometriosis, but also other factors like mentioned before by Matthias, for example, thyroid disorders or other problems like deficiency in vitamins. And then you have to think about how severe is the endometriosis, and is there a need, for example, for surgery due to life quality? This was also mentioned by Matthias. And then it's very important to do a step-by-step treatment plan for the couple.
Thank you very much. Stacey, you conducted a survey on women when talking a little bit about a different aspect of the perception of the disease, going beyond this bodily integrity. And you asked women to answer about the women's life decisions and goal attainment, and found that most women with endometriosis somewhat agreed or strongly agreed that the disease caused them to lose time in life, that they feel less positive about the future and feel they had not reached their full potential. So all four of you, and also you, Nicky, you conducted a lot of qualitative research here. Could you talk a little bit, Nicky, about this sphere beyond the physical integrity, and talk a bit about the quality of life that is affected, about the impact on mental health, sexuality, intimacy, and relationships, or just the ability to work normally?
Yeah, sure. And I think that it's a really important point in the context of the previous point about, weighing up the balance of side effects from medication and treatment versus issues around quality of life. So we did some research a few years ago now with cisgendered heterosexual couples where the woman in that couple was living with endometriosis, and we interviewed the men and women separately, and we found, similarly to much of the work that had gone before that had just included women, that endometriosis has a profound effect on all dimensions of people's lives. And that can include things like, as you say, it can include decisions about having children. Even before people may or may not come across the issue of infertility, people were deciding very early with living with the symptoms whether it was something they felt that they could proceed with. Living with a chronic condition and having children. Obviously, then there's the issue of fertility, if that comes into play, but also we've already heard the impact on sex and intimacy, and things like planning for not just kind of future activities, but immediate activities. So whether they could go out in the evening or go on holiday, or so it had a profound impact, not just at the individual level, but at the couple level as well. So the couples that we spoke to talked about how it had really reconfigured their kind of joint plans for their marriage, for their relationship. And interestingly as well, and this comes out in other research, it has an impact on people's perceptions of themselves in relationship to our kind of ideas of gender norms. So what it means to be a woman, and and actually for the male partner, what it means to be a man. Because what we found, for example, was that women were going part-time in their work or stopping work altogether. And so couples that we spoke to sometimes said, we've become this 1950s couple because I stay at home and he goes out to work and he's the breadwinner, and I, don't feel I contribute financially. So it has a huge ripple effect on all aspects of people's lives, both individually and kind of in relationship to their partners, but also beyond that with children and wider kind of networks, friends, family, and so on.
Yeah, that's disheartening, and stresses how important it is to have these conversations like we do have today to change the narrative in the future. So yeah, that women can equally go to work and not stay at home. I want to incorporate some of the questions we are getting from our audience to Matthias Beckmann first. How big is the group of asymptomatic patients that you spoke about? And maybe related to that, how effective are common non-steroidal anti-inflammatory drugs for treating endometriosis pain?
Answering the first question, when you came up with the questions, the funny thing was everybody was starting to smile. We do not know. How can we know that a woman has asymptomatic endometriosis? The only reason why I know this is if I do an operation for another reason, then I find endometriosis. And then I can ask a question to the woman, do you have any complaints, infertility, pain, or other things? And if she doesn't, then she is one of those women who do not have any complaints at endometriosis. So therefore, sorry, I cannot answer this question because we do not know this group.
Let me put it differently. Do you have a guess?
Okay. I would guess, I would answer in that way. In Germany, we have the data from the hospital submission with the diagnosis of endometriosis, which is NADA in ICD code, which is international. And in the last 10 years, the number of hospital admissions has increased from 22,000 to 43,000. So it has doubled in 10 years. So either there are more women who have endometriosis, Or, that is my guess, there are more women who are diagnosed with endometriosis and therefore admitted at the hospital. And then we have the other group, which takes, as I said, medication, hormonal treatment, or painkillers. And overall, I would say a third, I would guess, and have endometriosis, are asymptomatic. We have like 10, 15% who have infertility, and the rest, 60%, to my guess, is those who have pain. So pain is a major complaint. Infertility is a smaller one, but we have also a group who do not have any problems. And they should not be treated. And that is one message also. If they do not need, they should not take hormonal treatment. They should not take painkillers, and they should not get an operation. If it is an accidental finding, do not do a big operation on a woman who has no complaints.
Yeah, we spoke about that in our preliminary chat. Matthias Beckmann and Bettina Toth that also when surgery is performed, that doesn't mean that the disease is over, and that it's so important to monitor these women. So maybe to the clinicians in the round, what would be your wish, or what need is there for what kind of infrastructure is needed to realize that the women don't get lost after they got their first shot of treatment, so to say?
A woman who, can I start, Bettina? We start first. If you start treating a woman with endometriosis and you are not successful, what I guess has nothing to do whether you're a good or a bad doctor. There are women who cannot be treated in a sufficient way or as they like it. Then the woman goes somewhere else. So you lose those women anyhow in the follow-up. So in the group, we do phone calls to the woman 2 and 3 years after the treatment to get any information about how is the progress, how do they do, and we lose about 30 to 40% of the woman. We don't have an address, we do not have a follow-up. We only get information from between 40 to 60, depending how long the treatment has been started before that.
Bettina Toth, do you want to add on that?
I only can confirm what Matthias said. And I think what Nicky said before, that's also the psychological aspect. And we have also nice data published on that. And also the coping factors in the partnership is very important. And so if you have patients and you treat them and you even might go through surgery with them and the pain still continues, I think it's very important to take the patient serious. So the complaints serious. And then to try other treatment options like psychological counseling, like different aspects. So I think this is very important to take the patient serious and to continue, like Matthias said, stay in contact, not to lose the patient.
Nicky, we have another question from the audience that we also spoke about, which is there an estimate on the economic burden of endometriosis? And maybe you can put that into context with other diseases like asthma or diabetes to make this more concrete.
Yeah, sure. Yeah, there's been various attempts to kind of evaluate the economic impacts, and that involves looking at both the direct costs of treatment, so surgery, medication and so on, appointments, but also the indirect costs of the condition. So thinking about some of what we've been talking about, you know, loss of productivity, days missed from work and so on. So there have been a few studies that was some research in Europe a few years ago now that estimated the cost to be around 10 billion euros per year in the UK, 12.5 billion euros per year in Germany. Those figures are old now, they're out of date, so I'm sure that will have increased as the numbers of people being diagnosed have increased, as Matthias suggests. The more recent analysis from a study in Australia suggests productivity is the main cost, and that equates to around $6.5 billion per year in the Australian context. And yes, as you suggest, it has, as part of those studies, people have pointed out that endometriosis has a similar social and economic burden to conditions like asthma and diabetes, are the two that are often used. But unlike asthma and diabetes, which have become a priority in kind of funding and, you know, the kinds of attention that they've been given, endometriosis hasn't had that. And I think that's an important and interesting distinction that I think you mentioned at the beginning, Anna, as many people, as many women experience endometriosis as diabetes, yet endometriosis hasn't reached that level of visibility in the same way.
Thank you very much. We have a couple of questions about the progress of the disease throughout a woman's lifespan. I don't know who wants to jump on that question or these questions, but the questions from our viewers are if endometriosis leads to an earlier menopause and why it sometimes gets worse during menopause. And related to that as well, can pregnancy stop the progression of endometriosis? I've heard from some endometriosis patients that they're told that by their doctors. So could you please, I don't know who wants to take this question first?
I can start with the first question because I do not understand the question. To my knowledge, endometriosis does not get worse if you go to menopause. To my knowledge, endometriosis goes better if you go to menopause. So the only woman where, to my personal opinion, endometriosis could get worse are those women who go for hormonal replacement therapy in menopause, because then they have the same as they had when they were premenopausal. So they push in a huge estrogen load or progesterone load. But anyhow, that would promote, to my opinion, endometriosis in that age group. So therefore, from my point, this is not correct, as you mentioned.
I'll add that we're just seeing in the first studies on this subject that there is a small, but there's some evidence of women who for the first time are being diagnosed with endometriosis after menopause, when they are postmenopausal. That mostly seems to be discoveries of endometriomas in searches for ovarian cancer, for example. Yeah. We don't really understand what that prevalence is. We don't understand what the implications are. There certainly is some dysregulation and changes in symptoms during perimenopause, which we know that the perimenopausal window can be quite wide and long for some women, yes, quite narrow and short for others. This is another area of, speaking to Nicky's point earlier about what we pay attention to and what we have been both clinically and scientifically engaged about, is that we also, just like endometriosis and other gynecologic conditions, we know very little about perimenopause, the menopausal transition. We know that women are very varied in how that is expressed and what their experience is, but we really don't understand what are the triggers for menopausal transition, what drives the duration, what drives the symptoms. And so that some women are reporting that their pelvic pain, for example, or their fatigue that they attribute to their endometriosis are changing during perimenopause. We know that that's true for some women. We just don't understand why and what the implications are, or even how prevalent that is.
Yeah, I'm really sorry. I was misreading this question. It was about perimenopause. Just very briefly, how about does menopause, and then I give it to you, Bettina, Toth, go symptoms away when a woman gets...
I want to jump in to Matthias' answer. I think it's very important to mention that generally speaking, women with endometriosis do not jump in menopause earlier. It's the only subgroup we have to be aware of are women with surgery on the ovary. So if you remove parts of the ovary or the whole ovary due to endometriosis, this might be a cause of earlier menopause, but not on a general base. Not every patient with endometriosis is having menopause early. I think this is very important to mention. And with regard to hormonal treatment, of course, we can continue with the treatment options we already have and add small amounts of estrogen, for example, because also patients with endometriosis might suffer from climacteric symptoms and definitely need treatment options.
Thank you all very much. With regards to the time, I'm afraid we have to leave the discussion here, and I want to give each of you the chance for a short concluding statement. So if you had to talk very briefly about one aspect that's the most important to you when talking about tackling endometriosis in the future, what is the #1 priority that should be taken care of to change the narrative of the disease in the future? Maybe we start with Bettina, Toth, and then we go in the order of appearance, so to say.
I hope it's okay that I mention a statement of Nicky, but I think this is so important because menstruation was so shameful for many women, and also talking about pain during menstruation. And I think it's very important when we think about diagnosing endometriosis earlier that we have to get rid of the shamefulness and that we really talk about menstruation, menstrual pain, and factors that might be linked to menstrual pain. And it's not only endometriosis. As I mentioned, there are other risk factors, but by talking about this, we might help in earlier time. And I think this is very important.
Stacey?
I would add, I mean, I agree completely. And I would add that as foundationally, we have to become more curious about women's bodies and how they vary, how they're similar, how they change across the life course. What aspects of endometriosis are specific to the reproductive system and menstruation, but what aspects are related to immunology, rheumatology, cardiology, neurology, and I know in many of the wonderful questions in the chats, there were questions about, we've mostly talked about hormonal approaches, but there are all of these other systems that can be intervened upon. And that really is the next great frontier, which is bringing in a multi-systemic, multidisciplinary approach for women across their entire life course.
Yes, Beckmann?
Two things. The first thing is we need more money for research. This is definitely for the first time in Germany. We have a program with 5 million euro to research funding for endometriosis. For the first time, we have 2024. And the second thing is that those women should be treated by specialists. Because I think we have disease like breast cancer. Breast cancer women are treated by specialists. Asthma people are treated by specialists. Rheumatologists treat people with rheuma. So I think endometriosis, a complex endometriosis, deep infiltrating or recurrent endometrioma, so they should be treated in special units or by special people or by special teams for getting the pest out of the side effects and to decrease the incidence of the disease.
And from me, yeah, 3 short things. One, improve medical education, particularly for GPs. A lot of what we know about is that women and others experience challenges with general practitioners when they appear. So improving awareness amongst general practitioners. One, including patient voices in any research we do. I think it's great that these programs exist and we should include. For so long, people with endometriosis have been left out of those discussions about the direction of what research should cover and how treatments should be developed. And then thirdly, just to think about intersectionality. And I mentioned earlier, when we talk about endometriosis, it's not just cisgendered white women who experience endometriosis, but to think about how endometriosis is experienced amongst a very wide group of people, trans, non-binary people, but also people from different ethnic groups, religions, and so on. So we can get that full picture of how the condition is experienced.
Great. Thank you all very much to the four of you. Thanks for these concluding remarks, for your insights, for your input statements, and for taking the time to engage in today's conversation. There are so many questions left in the chat. There's so many questions more on my mind to fill another 3 rounds of discussion. For today, I'm afraid we'll have to leave it at that. One can say that we just at the beginning of this journey and that it's important to start the journey. A video recording of this conversation will be online on Leopoldina's YouTube channel within the next couple of days if you want to re-listen to some of the aspects that were mentioned. And even though we may not have solved the problem of endometriosis today, which would have been a very great endeavor, I'm sure that this panel discussion has at least opened a door for future conversations about this understudied disease. So I wish you all a very great rest of the day, everyone, and see you soon. Goodbye.